So I was trying to give you a little update on where we are with COVID, but start off with a little biology, just a little bit, and then kind of launch into, sort of trends and vaccines and where we're going and how we're going to get out of this. So COVID is a coronavirus, and coronaviruses are large RNA viruses that have mucoid envelopes around them. So there are two types of viruses. There are RNA and there are DNA viruses. This is an RNA virus where its genetic material is ribonucleic acid as opposed to deoxyribonucleic acid. And it's and the RNA ones are smaller than the DNA ones. RNA viruses are very prone to mutation. This being a large RNA virus has has an enzyme that will do repair of the gene as it replicates. So these tend to mutate less rapidly than others like HIV, but still they do mutate, and it's no surprise that we're dealing with variants. On the core of the coronavirus, all coronaviruses, is the spike protein or the S protein, which is this guy sticking up here. And that's think of that as kind of like a Velcro stick, right? And as the virus tumbles down the respiratory tract or in the back of your throat or your nose or in the conjunctiva of your eyes, it will stick to these so-called receptors that are they're angiotensin converting enzyme type 2 receptors, if you want to know the details. But the spike protein at its tip has this kind of like key, which is called the receptor binding domain. And that fuses with these enzymes, with this cell surface receptor, and it allows the virus's RNA to be injected into the cell, take over the cell's machinery. The way this virus is spread is by two routes. It's primarily by respiratory droplets, which are larger. I mean, these are particles that are big enough and heavy enough to not remain suspended in the air. And kind of the rule of thumb is that they can travel for 1.5 meters, which somehow we've translated to 6 feet, but it's 1.5 meters, before they fall to ground. The other way, which seems probably somewhat more common than we originally thought, or so-called aerosol or airborne spread, where viral particles, these are respiratory particles when you breathe out. Think of what your breath looks like in the wintertime when you're outside. Those are respiratory particles. The viruses, those are small enough that they can remain in suspension in the air and can float around and travel sort of longer distances, be picked up by air handling units and recirculated. Although it's theoretically possible, there's no evidence yet for a surface transmission, meaning so-called fomite transmission. So somebody, coughs on the hand on the rail in the subway train, and you go grab it, and it's the same place. Get your hand all wet, and you wipe your eye with it. That would be fomite transmission. It's about that. It's about that easily done. It's pretty, it's not very easily done with this virus for whatever reason. So the other thing to remember is that masks are highly effective. I'm sorry, I just want to say infectious. Highly effective in transmitting, in preventing transmission and acquisition. So if you have a mask on and you're infected, you're not going to be exhaling many particles. If you have a mask on and you're uninfected and someone's exhaling particles on you, you're less likely to get infected as well. And what CDC says is to now has passed out advice around wearing 2 masks, a regular surgical mask and then a cloth mask over it, or a regular surgical mask and an N95 or a KN95 over it, or 2 regular surgical masks. And I can show you all this when we get to show and tell. Worldwide, there have been over 100 million cases that have been reported. This is since late December last year, or in 2019, I'm sorry. There have been almost 2.4 million deaths. And while we're kind of we had an early wave here, a second wave in here, and then we're kind of in a third wave here, and it seems to be going down, although in certain places it's still holding on. In the United States last week, these are the 5 countries with the most cases. We've cut our rates in half. We had 673,000 cases reported last week. Brazil had 318, France 127,000, Russia 104,000, and the UK 98,000. In both the United States and California, the cases are falling. These are numbers because the WHO does these on different weeks than the New York Times. So we've had yesterday, we had an additional almost 60,000 cases in the US. And you can see up here at the peak, we were running close, more than 250,000 cases a day. So you can see how far this has fallen. We've also continued to have mortality from this and had almost 1,500 deaths yesterday across the country. That's the average number over the last 7 days. California has, with about 15% of the population of the country, has about 12% of the cases and 7% of the deaths. And you can see that California has had, we had 4,972 new cases yesterday, which is way, way down from our peaks, which are up in here in this sort of saddle-shaped distribution. And we were well in excess of 40,000 cases a day, and we're now down to 4,900 cases a day. And similarly, mortality has started to come down with almost 50,000 total deaths in California and 191 yesterday. The big shocker is that we've crossed 500,000 deaths as a country. This has been associated with a decrease in life expectancy in the United States. We've lost, and this is just through June, and it's annualized from, they took what happened from January to June and doubled it basically. So this is annualized, so you don't get that big second surge. You're not really getting that fully represented. But if you annualize from up through June, the US has lost a year overall in average life expectancy. And you can see it's not evenly distributed. So for African-American males, they've lost 3 years. For Latino males, 2.4. For African-American females, 2.3. For Latina females, 1.1. For white males, 0.8. And for white females, 0.7. This just came out last week. It's sort of a shocking thing. Here in California, and I understand a lot of you are in California, so I'll show you what's happening here. Here in California, there are, most of the cases have been down here in Southern California. By most, I mean 60, 70%. It's really damped way down with only a handful of counties reporting, even in per capita basis, sort of a dark, more cases. Inyo, Lassen, this is because there's a jail there. This is Glenn or Colusa, one or the other. And this is Stanislaus County. But you can see the big counties in terms of cases. Los Angeles, big drop. San Diego, big drop. Sacramento, big drop. This is in the last week. Riverside, Orange, San Bernardino, Ventura. Ventura's right here next. This is Los Angeles. This is Ventura, San Bernardino, Riverside, Orange, the surrounding counties. But then the big valley counties like Fresno has also dropped. And then Santa Clara, where a lot of you are, has dropped as well. And people say, why is California doing so poorly? The question, that's not the right question. The question is why we're doing so well. We're below the median number of cases per capita for states, and we're well below the median in number of deaths per capita among states. So I can show you some of the statewide indicators here in California. There's a number that you should walk around with in your heads. It's called the effective reproductive number. This means, on average, how many secondary cases will each infected person cause, okay? So if it's more than one, if the number's more than one, the rates will go up. If it's less than one, the rates will go down and you'll eventually extinguish the transmission If it's 1, it'll remain 1-to-1 replacement, and that's called endemic disease. So right now we're well below 1. This is the lowest I've ever seen it. Only 3.1% of all the tests being done in the state are positive. You can see it was up here in the 14s not that long ago in January. We've had a big drop off in hospitalizations from its peak, but we still have 6,500 people in the hospitals, even though it's down 42% from a couple of weeks ago. Overall, the ICU capacity is 17%. For a long time, it was 0. We have, these are not insubstantial numbers of deaths, as you know. But in California, there's this complicated system of tiering, T-I-E-R, not T-E-A-R, that has that assigns colors and says how much can open and how much can't open based on the color scheme. Basically, all the counties in California are still in the most restrictive layer of that most restrictive tier. And there are just some very small counties, Del Norte, Mariposa, Plumas, Alpine Sierra, and Trinity. These are all either in the far northwest or in the Sierra that are in these less restrictive tiers. Okay, so that's what's going on in the U.S. and California, and I'm happy to answer specific questions when we during the Q&A. Now, this is a cautionary tale. So Europe had a big nasty surge in October and November. The French moved to lock everything down, and everybody had to shelter in place in their apartments or at their houses or out on the farms. And it basically dropped off. And the British did something very similar, maybe not quite as stringent, but something very similar. They got a drop off. And then all of a sudden, their cases started to go up and said, uh-oh. Well, meanwhile, everybody else, France, Germany, Italy, they're all down, Spain. And said, uh-oh, what's going on? And what was going on? Well, this was going on. This is the Friday night before Christmas. Okay. I guess this must be Bond Street. Anyway, there's a mask. There's a mask, probably. That's a beard. Don't get carried away here. But you can see, oh, there's one right there. Not a lot of, maybe there's one there too. But not a lot of masking, right? And so everybody said, oh, this is all behavioral. This is just, increased transmission because of all the Christmas shopping and all the stuff that goes on in London during Christmas. It turns out that there was a mutation involved. And this is the so-called UK mutation, whose official name is B117. And this is a strain of the virus that's been kind of kicking around slowly since September, but has now had a huge outbreak in Greater London and Southeast England, spreading around the country. And it's accumulated a lot of mutations. This has actually 14 structural mutations in it. And the structural mutations on the spike proteins, if you can see my hands, sort of change the configuration. So the antibodies have a harder time attaching. And some make the configuration such that the virus has an easier time attaching to the cells. So this is the N501Y. That actually means something in molecular biology land. This is one amino acid for another. And it's caused up to 20% of the infections in southeastern England in December. There was concern that children may be more susceptible. I've actually heard that was never really proven very well in Great Britain, but we're hearing the very similar reports from Italy right now. And they thought that the effective reproductive number, this is actually something called the basic reproductive number, which is very closely related, went up from, say, around 1.1 to up to 1.5. So for every one case, instead of having 1.1 new cases, they'd have 1.5 new cases. That would cause 1.5, and each of those would cause 1.5. So you can see how it starts to grow exponentially. While there was no evidence of resistance to mRNA, vaccine-derived antibodies, and no evidence that with the PCR doesn't work, and no evidence that there's resistance to monoclonal antibodies, it is possibly associated with more severe disease. So this is a complex story, and we're watching it unfold, and we're watching it unfold in real time in California. So this is just gives you an idea of what's going on here. This is this is one thing that people don't realize is that back in March and April, there was really a wholesale replacement of the Chinese strains with a couple of European strains. This became the dominant strain in the U.S. But here's this newer one that's kind of popped up here in November and has grown to at this point in time to account for about 30% of all isolates in the UK. Okay, so let's talk about these guys. So there's several point source mutations that we worry about, but we also worry about accumulation of numbers of mutations. But these are the individual ones. This is the one that appeared in early 2020 and really spread around the world and displaced the Chinese variants. This is one where it's an N for a Y, which is in the UK lineage mostly, and this is the one that helps it bind more tightly to cells. This is another replacement that appears in a South African variant and a Brazilian variant, and this makes this changes the configuration of the spike protein, so it's less. So antibodies have less room to land on the spike protein and attach to the virus and mark it for killing. And then here in California, there's been this, I think it's 450, no, that's 420. Anyway, there's been this other variant, which has become increasingly common in California. We don't really know that much about it yet. It seems to be susceptible to the vaccine. It might be somewhat more easily transmissible. That is, it binds a little bit more tightly. It's a little stickier to the cell receptors. But this is something that we're really keeping our eye on closely. There are the big labs at Cedars-Sinai and in UCSF and Stanford are all working this up very quickly. Now, these are the individual mutations. These are errors in codon transcription. So when you might have adenine, whatever it is, uridine, adenine, right? And ends up getting coded as adenine. That changes the amino acid, okay? So those are those little triplets that you learned about in molecular biology. When one of those gets messed up, dropped out, so you take the next one over, or it gets replaced just through a coding error. That's what changes these amino acids, and that's how these mutations happen. Some of it happens randomly, but which strains live and which strains die off depends on how well they are adapted to the environment in which they are. So as we get more vaccine out, we might see more of this mutation around because it's more likely to evade the vaccine. It's not really, but it is theoretically more likely to evade the vaccine and can basically outcompete the other strains. When you take these things across the board, so this is the UK strain that I talked about. This is the South African strain, which has this mutation that makes it somewhat less susceptible to the vaccines. And then this P2, which also has this name B11281. And this is just lineages that we're talking about here. This is the Brazilian strain, and this has similar mutations as the South African strain. Here in the US, where we've started to do I don't know how to characterize it, not particularly comprehensive job of doing surveillance for these variants. We found 1,661 of the UK variant, 22 of the South African variant, and 5 of the Brazilian variants. In California, we have 195 of the UK variant. A lot of those are in San Diego County. None of the Brazilian variants, and then 2 of the South African variants. One in a person who lives in Santa Clara County, and the other in a person who lives in Alameda County. The one in Santa Clara County, we know was someone who traveled, and when they came back, quarantined, and basically there's no chance of spread except to one person in the household. So the Santa Clara one seems to have taken care of itself. The Alameda one is a little less clear. And this just shows you in California. Here's this California variant. This is the one with the L452 R. It's a leucine to arginine transformation. Right? You can see how that's increased both statewide and then especially in Southern California as as one of the main mutations that we're seeing. And CDC thinks that the British mutation, given certain parameters, this is all modeled, given certain parameters, will become the dominant strain in the United States by April. And we're certainly seeing that in California now, where as you could see that that's becoming an increasingly large number of cases with the variants, 195. What you don't know is how many sequences have been done. And I suspect it's on the order of hundreds of sequences, and maybe it represents 20%, and that proportion is growing. Okay, so problems, trouble. Then the Biden administration comes in, and its first day on the job produces this document. Guess it was probably written already, just guessing. These were the 7 points that it made for the strategic plan. Restore the trust of the American people, mount a safe, effective, and comprehensive vaccination campaign, which you're seeing right now, mitigate spread through expanding masking, testing, data, treatments, healthcare workforce, and clear public health standards, immediately expand emergency relief and exercise the Defense Production Act, safely reopen schools, businesses, and travel while protecting workers, protect those most at risk and advance equity across racial, ethnic, and urban-rural lines, and also against older, younger lines, and restore U.S. leadership globally and build better preparedness for future threats. Okay, so a big part of this is the vaccine. So this is a huge breakthrough. This is a true miracle of molecular biology, and this is the culmination of the last 70 years of research in molecular biology, starting with James Watson and Francis Crick and Rosalind Franklin at Oxford in the late 1940s, where DNA was discovered. This is where it's gotten us. We were able to produce a vaccine in essentially record time. From the day the virus was first isolated in Wuhan to the day that it was sequenced, where we knew its entire genetic sequence, was 7 days. Okay. In time from that to having the first candidate mRNA vaccine was about 2 months. That's astronomically fast, but it's also astronomically accurate because we have this new technology that's been in development for the last decade that we're really getting to start to deploy now. And that's using messenger RNA as the vehicle to trick the immune system into creating high levels of antibody and high levels of T cells, the other part of the immune system, the cellular immune system, trick them into recognizing, doing a better job of recognizes SARS-CoV-2 as foreign protein, glomming onto it and having it killed off. So we have 2 of these vaccines, one made by Pfizer, one made by Moderna. There are a couple of differences. The Pfizer vaccine is authorized for people 16 and over, the Moderna for 18 and over. The Pfizer vaccine is given on a 21-day interval, the Moderna on a 28-day interval. Those are soft intervals, by the way. CDC says you can go out to 4 months. You can also get it maybe 4 days earlier. So that's there's some grace period on that. These are not interchangeable. If you start with one, you should finish with the same one. There's some contraindications, current or recent infection. Basically, this is not a real contraindication. This is just about you're going to get naturally acquired immunity anyway. Go to the end of the line, and then you can get vaccinated again. We're not sure how long naturally acquired immunity lasts. We're not sure how effective it is, especially in the face of these new strains that are circulating. There's some known allergies to components, especially something called polyethylene glycol, which is one of the, so they have to coat the mRNA in something, and this is one of the chemicals in that coating, and people have had reactions to it. The safety profile is not that well established for immunocompromised people, aside from HIV, but it's not a contraindication. There's no contraindication for autoimmune disease like lupus. Those patients were included in the trial. There's no contraindication for Guillain-Barré syndrome or Bell's palsy, which is a seventh nerve palsy, which have been implicated with vaccines in the past. And there's no contraindication for either pregnancy or lactation, although the pregnancy is, that's being evaluated now prospectively in another trial by these manufacturers. By Pfizer. How are we doing giving out vaccines? Not bad. The US is fourth in the world in vaccines administered per capita. California is pretty far up there. We've had about 7.5 million doses administered. We're cranking along at a little under 200,000 doses a day. Almost 14% of Californians as of this morning had received a single dose, and 5% had received 2 doses. You can see this sort of sorts where the population is, with Los Angeles, San Diego, Orange, Riverside, these are the big Southern California counties getting it, and then Santa Clara, Alameda, the bigger Northern California, Bay Area counties getting it. And then you get down here. Well, I worry about San Francisco all the time. I realize you guys are in Santa Clara, but we're doing okay. We're doing okay. 185,000 people vaccinated in a city with 900,000 people. That's San Francisco, of whom 100,000 are children who aren't eligible. So that means 800,000. That's looking not bad. Plus, you have people with naturally acquired immunity, which is a big deal in Los Angeles, Riverside, and San Bernardino, because they've had such high case rates. They have a lot of people who've been naturally immunized. We're kind of moved out of phase 1A now. This was about 3 million people, and we're down here at 7 million. That's for healthcare workers and residents in long-term care facilities. Phase 1B has each of these groups is about 6 million people 65 and older, and then people who work in agriculture and food, education and childcare, and emergency services. This is all about getting teachers back in the classroom, or this is part of that, okay? And then in a couple of weeks, healthcare providers can also request that patients be vaccinated who are between 16 and 64, who have high-risk conditions, of which there's a list. Now, so here's a question about, can we really see an effect of the vaccine at the population level? And I think this is really kind of a compelling story. This blue line are people who live in nursing homes, and the red line is everybody else. So remember, in phase 1A, we started to vaccinate people in nursing homes first. And what you see here is this drop-off in cases in nursing homes about 2 weeks before you see it in the general, 2 to 3 weeks before you see it in the general population. And I think this is the effect of a single dose, 1 dose of vaccine, that there was enough partial protection provided that you see this very rapid drop-off in cases. Okay. So I'm going to ask 5 questions, ask and answer 5 questions about vaccines. The first is, what other vaccines will be authorized by this summer? The Johnson & Johnson vaccine, which is 1 dose, will be authorized probably next week. There's a Novavax protein that's it's not one of these fancier technologies like adenovirus vectors or mRNA. That's just a straight up protein vaccine. I think that'll probably be April-ish, and then AstraZeneca, Oxford, is being used in a number of countries, including the UK. It probably won't be ready for prime time here until April as well. So the second question is, well, can you just get a single dose? Do you really need 2 doses? So the British say, So first of all, you do need 2 doses. That's what we know works. But you do get some protection after a first dose. And if you look, and this is from the Moderna trial, okay? So you have people who got vaccinated here on day 0, and they get revaccinated on day 28. It takes a couple of weeks for this stuff to work. So let's look at from day 15 to day 28 and say, okay, how many people got infected during that period of time? And what they found is that in the vaccine group, there were only 2 cases, and in the placebo group, there were 28 cases, which is the equivalent of a vaccine efficacy of 92%. Now, we don't know how long that lasts, but you get the idea that this is 1/15 or 1/14 of this level. These are data from Israel that there's a big to-do in the press last week, and this is also after a single dose. Look at the 15 to 28 day window for symptomatic disease, that is clinical disease where people are sick. It's 85% protective. And for just looking at whether they get infected or not, just looking at the viral protection against infection, they're 75% effective after a single dose. There's a similar data from the Moderna trial. I've said, can vaccine prevent asymptomatic infection? And these are, here you can look at exact same idea, days 15 to 28. This is how many cases there were in the placebo group and how many cases there were in the vaccination groups. They had 20 here versus 293 here, right? But of these, 39 were just the virus infection, and here 15 were just the virus infection, right? And so if you do the math here, you end up with a vaccine efficacy of 62%, about the same as the 75%. And here, if you look overall at both symptomatic and asymptomatic, they came out with 89.5%. So you see that these things are all kind of roughly landing at the same area. Okay, next $64,000 question: how well do the vaccines work against the variants? Okay, the UK variant appears to be fully susceptible to the current vaccines we're using. The South African and Brazilian variants appear to be less susceptible, but not totally unsusceptible. And their protection may be more from severe disease than from actual viral infection. There are, in fact, some scant data now on the California variants, and they kind of look like the UK variants. They appear to be just as susceptible to the vaccine as the wild type strains we see. And I got this from the South African National Blood Service, who for inexplicable reasons to me likes to put smiley faces on things. They've decided that the AstraZeneca vaccine, based on its protection against viral disease, just not the symptoms, but just the infection, wasn't good enough for them. So they've canned this. But you can see that J&J, the Johnson & Johnson single dose, that got a big smiley face. And some of the laboratory in vitro assays worked well for Pfizer, okay for Moderna, and well for Sinopharm, which is a Chinese vaccine that's available in South Africa. Okay, and the fifth question is, when are we going to reach herd immunity? So I did yet another interview today with the Chronicle where they said, has any place in the Bay Area reached herd immunity? To which I replied, yes. San Quentin. You need a closed population in order to achieve herd immunity. You can't have people coming in and out of it who are non-immune. And so while we can talk about what proportion of people we need for herd immunity, and you can see over here at some of the larger prison outbreaks, this is where the percentage is infected is up here. Look at this blue line, right? They're all over 60%, and in some places they're well over 90%. Here at the glamorous Chuckwalla State Penitentiary out in the middle of the Mojave Desert. But you can see how these things are all kind of well in excess of 60%. And so I always say, oh, that's around 70%. That's about where we would see herd immunity. What that means is now the virus can't find the next person to infect. I mean, speaking anthropomorphically here. So susceptible individuals can be protected from an infection from human to human if a sufficiently large proportion of immune individuals exist in a population, right? So we'll be unable to sustain an epidemic due to lack of contact with a sufficient number of susceptible individuals. This is the formula 1 minus 1 over the effective reproductive number. So if the effective reproductive number is 3, this would be 1 minus 1/3, which would be 67%. If it were 4, this would be 75%. It's somewhere, I think it's about 3.5. So that's kind of where I think you have to be, in the high 60s, low 70s. And it can come from both naturally acquired immunity as well as from vaccine acquired immunity. And I think one of the reasons you're seeing these very rapid drops, especially in Los Angeles and the kind of peri-urban areas around Los Angeles, is because of naturally acquired immunity. They've had such big outbreaks there that people actually have their own antibodies without virtue of ever being vaccinated, and they're protected as well. And the other thing to say is that the B.1.1.7 variant and the California variants that appear to be more transmissible, what that means is that this is a higher number here. So let's say instead of 4, it's 5. So instead of being 1 minus 1 over 4, it'd be 1 minus 1 over 5, or 80%. So if you start getting replacement of these with these more transmissible strains, herd immunity is going to be at a higher level. And I'll just end with your with where you can get information about the vaccines. This is the new website that's actually now working pretty well as a place where you can sign up for vaccines.